when I start looking at the larger pneumothoraces, greater than 20%, I have a choice. I can either do needle decompression or I can do what's called a thoracostomy chest tube. So depending on what's going on, right? So if it's a little bit smaller pneumothorax, you can do needle decompression. This is where we will go between the second and the third intercostal space, and we always go above the rib. Always go above the rib, mid-clavicular, so in the middle of the clavicle, between the second and the third intercostal space, above the rib, we can puncture that area with a needle and pull the needle out and allow the catheter to eject the air that's in the pleural space. The other probably more common procedure that we see is that thoracostomy chest tube. And this goes between the fifth and the sixth intercostal space, mid-axillary. So this is going to go underneath the armpit between the fifth and the sixth intercostal space, again above the rib, because we want to avoid any nerves, arteries, or veins that run below the rib. And what we're going to do is there is a surgical procedure to put or to insert a chest tube. Now, when we insert a chest tube, if it's air, we want to go to the top of the lungs. If it's fluid, we would go down to the base of the lungs, just like what we talked about before. Air rises, fluid falls. And so depending on what I'm trying to drain, I would redirect the chest tube itself, the catheter, to that area. So after we get the chest tube in place, we'll connect that to a water seal so that all of the air that's escaping now out of the pleural space can escape out, but whenever that patient breathes in, there's not a place for air to come back in because that tube is submerged in a water seal. So it does not allow air to get back into the pleural space, only allows it to evacuate. We can attach the chest drainage system, and we have single bottle, double bottle, and triple bottle. Even now there's a four chamber chest drainage system that we will look at some point that you can connect to the suction at the wall. You don't want your suction to be very high at all. And what that does is that encourages more evacuation of that air. And what we want to do is we want to keep that chest tube in until that lung is fully re-expanded. And how do I know about that? Well, if I have my chest tube in place and it's in the water seal, it's going to move air into that body of water. Anytime that you blow air into a body of water, what do you get? You get bubbles, right? So if we get to a place to where we don't have bubbles anymore, and we don't have those bubbles for a period of time, we can clamp the chest drainage system. And as long as that lung does not deflate while we have that chest tube and that chest drainage system clamped for about 24, sometimes 48 hours, then that entire system will be good to come out. But one of the things we have to be aware of is if there is no bubbling, this can actually be a bad thing too, because I can kink or I can clamp the tubing and that would stop the bubbling as well. So I just have to be aware of, is this bubbling or is this not bubbling because there's a kink, or has my patient healed? So you have to be aware, you have to be watchful of the bubbling with the chest drainage system. Now, the last things that we want to look at are treatments here: oxygen, lung expansion, mechanical ventilation if it gets bad enough, and pleural desis. You want to maintain your oxygen status so that they're not becoming hypoxemic. You want to do all the efforts to help them reinflate those lungs, and in the event we have to take over, we don't love doing it, but if we have to, we will. We will put the patient on mechanical ventilation and assist them through their time of healing. The pleurodesis, let's talk about that a little bit more. So when we look at pleurodesis, this is actually us instilling a sclerosant agent. The most common sclerosant agent that you will probably see is talc powder, and that's injected into the chest cavity. So the talc powder or the sclerosant agent is injected into the chest cavity. This is a medication that causes really an intense inflammatory reaction over the outer surface and the inner surface of the chest cavity. So that inflammation, any leak or opening that's there is sealed through the inflammation, and it causes the surface of the lungs to adhere to the chest cavity. It prevents or reduces, really, it doesn't always prevent, but it reduces the recurrent pneumothorax and recurrent pleural effusions. So we'll see pleurodesis being part of the treatment for pleural effusions as well. This can actually, though, cause intense pleuritis, which is intensely painful pleurisy. So talking with patients after they've had chest tubes or this pleurodesis procedure, anytime that we are in and manipulating the pleural space, the patients tend to complain about pleurisy or that painful chest pain. But what I want you to do is I want you to kind of connect pleurodesis with the sclerotic agent and talc powder. Highlight talc powder. That is a identifier for managing either a recurrent pneumothoraces or recurrent pleural effusions. So those are two treatment plans that we have when it comes to those two conditions. So that's what we have when we have flail chest and we talk about pneumothorax. We've got the etiology with those, we've got the pathophysiology, we've got the clinical manifestations. Diagnostics is really going to be imaging when it comes to both of these, whether it's with a chest x-ray or with a point of care ultrasound. There's not a true lab value that stands out when it comes to either one of these. Sudden onset with both of them, not typically, but most of the time, or sometimes it's caused by some sort of traumatic event. So we will talk about these again when we get into our traumas.